My name's Leanne Murphy. I'm going to be a bit of an MC today as well as a presenter. We've got this beautiful panel here and we're going to be talking about incontinence. Let's talk about continence health in Hobart with this beautiful view. Firstly, I'd like to do a formal acknowledgement of country, and we've got this beautiful area here. So I pay my respect to the traditional and original owners of this land, the Muwi-ni-na people, to those that have passed before us, and acknowledge today's Tasmanian Aboriginal people who are the custodians of this land. So I'm going to start by giving you a very brief overrun of my personal story. So I had a 4th degree tear, so I will be going into some graphic detail. So I won't say a trigger warning, I'll just say a content warning for my story. In 2009, I had my son, Connor, so he's in my arms, and my daughter Molly is in my belly. I had a normal vaginal delivery in a private hospital in Melbourne. As you can see, it was 14 hours, it was 2 hours of active labour, 20 minutes of pushing. I was stitched up in the birthing suite, but there was never any mention of the degree of tear, or if there was tearing, I was just stitched up. I was discharged after 5 days as normal. I actually had a beautiful hospital stay. It was a magical moment bringing my son into the world. My obstetrician was lovely, my husband got to stay. It was a very positive experience, or so we thought. So we left there on cloud 9 with our first child, amazing. But I did actually have 3 major red flags, and these were discussed multiple times with multiple people, whether that was the maternal child health nurse teams, my local pelvic floor physios, and my obstetrician and gynaecologist, which I saw after. So my red flags were that on day 4 of my hospital stay, my stitches broke down. I was still discharged with my wound and my stitches not redone. I got the E. coli infection at home. I was sent back to my obstetrician and my stitches were redone on the consulting suite tables with local anaesthetic, which did not work. So I was stitched up on the table while my husband and son were behind that paper curtain, and I was screaming and crying my eyes out. And after that, I had, well, it's 0 flatus, but I would say I had no control of my farts. And I knew that from the 4th day. So we're here to talk about what we said. So let's talk. So what I said was, I cannot control my wind. I farted in the lift with my boss. I was mortified. So when that happened, and I went into detail, still no red flags. I have skids on my undies, and I only wear black undies now. How long until this gets better? And I feel like there's bubbles travelling from front to back. The replies to me were, it can happen, there's nothing to worry about, you've just had a baby, it takes time. Yes, even after 6 months. Are you in any pain? I wasn't in any pain. Is there anything unusual? Well, it's my first child, what's unusual? And does it hurt to poo and wipe? No, it didn't. My obstetrician actually said to me, and remember, I had a positive experience and I liked him, loved him, at the next birth I'll do an episiotomy and I will tidy you up down there. I actually thought that was a good thing. I actually thought, oh well, that's great, he's going to look after me. And he said, don't worry, I will look after you. Famous last words. My second birth. This is my daughter Molly, born 21 months after, so nearly 2 years. I had a subsequent normal vaginal delivery. That blanket that you see across from me is because I'm covered in blood. My husband has put a blanket over me for this first photo of me holding my child. It was 12 hours, 2 hours active labour and 5 minutes pushing. There was no doctor and no midwife in the room, in a private hospital in Australia, the lucky country. I sustained a catastrophic 4th degree tear which left my anatomy unrecognisable. I had no skin between front and back. Every step after that day was... It was completely open. I was not repaired in hospital. I didn't have my 4th degree tear repaired. So I left with a gaping wound. So on my days whilst I was in the hospital, postpartum, trying to breastfeed a newborn and have visits with my 2-year-old, the nurses would come in and say, I've got a note here to check your wound. Okay, show them, oh, you've got a gaping wound. What are they doing about that? I've been told I'll have a repair under general anaesthetic. Great, okay. That's what I believed. The next nurse, so you'd have a morning nurse, an afternoon nurse, and the matron would visit, or what they call the num. So 3 people every day. So 5 days, that's 15 opportunities for someone to say, hey, this lady doesn't have her name on the list for theatre. Why hasn't she been repaired? Why hasn't this girl in room 3 actually been repaired? But nobody did anything, and I didn't know. So what actually happened? So I ended up having an endo-anal ultrasound, and it was discovered that I had scar tissue from 2 years prior, which was Connor's delivery, that was actually an internal sphincter injury. So that is called an OAC, so an obstetric anal sphincter injury. And when Molly birthed through my birthing canal, I was torn from that internal anal sphincter injury all the way down to my perineum. So it was an undiagnosed 3rd degree tear from my son that led me to having a 4th degree tear. So I ended up having an ileostomy bag because I had no flesh. There was nothing there. So I had a bag, it was ileostomy, but it took me 6 months to find a surgeon. No surgeon would operate on me. I don't want that on the books. I don't want a bad outcome. I don't want my reputation ruined for you. You will not have a successful repair. I don't want you on my books. 6 months, I'll remind you, every moment. Poo falling out of me. Post-baby bleeding. Crossed over pads. I didn't actually know of any continence aids. I was managing myself with maternity pads, crossed over, front and back. I had garbage bags on my bed because I was pooing overnight. It was falling out of me 24/7. And breastfeeding, and a 2-year-old. I genuinely thought that I would be fixed. When I had the bag, because I had been completely isolated for those 6 months, this was amazing. It literally was like, yes, finally, I can leave the house, I can go to the park, I can go to the shops. It was an incredible feeling of freedom. I could be a mum again. But the surgeries continued. I had surgeries for 6 months. 6 surgeries over 6 months. I was over 50 days in hospital. I'd be in for 5 days, out for 5 days, in for 10 days, maybe 3 weeks, but I never knew. So I was trying to explain to my very inquisitive 2-year-old, yes, Mum will be back. Oh, when? Oh, actually, mate, I don't know. Like, it was just so gut-wrenching, it was terrible. So Connor would actually, and I'm still trying to breastfeed my newborn, who at this stage is 6 months to the 12-month mark. She drops from the 50th percentile to the 5th. Connor asks, when am I going to get my bag, Mum? Because it's completely normal that he sees his mum with an ileostomy bag. Paddy has to take 6 months off work because we've got all the bills coming in and we suffer financial hardship. We eventually have to sell our house and move because we cannot pay our bills. Can she stay too? Well, Molly's not considered the patient. So I'm breastfeeding a child, but I'm no longer a maternity patient. I'm a colorectal patient. So you're trying to breastfeed and bond with your newborn, and she can't stay in the hospital. You have a surgery, you have to wait 24 hours after your general anaesthetic before you can breastfeed. Now it gets grim. I am in utter despair. The ileostomy is reversed, hooray. Surgeries are over, but I am actually now still so badly faecally incontinent that I actually don't know that there's any end in sight. So my anus is repaired so narrowly that it's actually not sausages that I see in the toilet bowl, I see shoelaces. The scar tissue is cut away and I am reconfigured. Where this was reconfigured, I was reconfigured like this. So my nerve endings now no longer talk to each other. I've got poo falling out of me. I've got to have enough Movicol to get a poo out, but not too much Movicol because I can't actually hold anything in. And again, and the smell and everything else, and the, constant nappies, rashes. The Sudocrem in our house was crazy. Take care of the Lifeline. My son was toilet trained before I was. My mind breaks. I can no longer read numbers. I don't know if it's 11 o'clock or 1 o'clock, and I probably shouldn't have been driving. But the healing began. Because I'd had 6 bowel operations, I couldn't have anti-anxiety or anti-depression medication because it would give me an upset tummy. And after 6 bowel operations, I couldn't have something that would give me diarrhoea. So I had to heal myself. And it took years, but eventually I would retrain, I'd become a counsellor, and I specialise in birth trauma healing. I wrote this book, and my children, Connor and Molly, are the illustrators. This is the book that I wish that I had to read to them at the time. And luckily, we made it. Thank you for listening. Now it is my absolute honour and pleasure to welcome Dr Premitha to the stage. She's going to talk to us.
Thank you. Good morning. Thank you for sharing your story with us. For some of you who don't know me, I'm actually from Kuala Lumpur, Malaysia. Have you been there? Yes. Good. That's great. Do you like it? Do you love the food? Yes. That's what everyone remembers about Malaysia. You love it, right? So go back and enjoy it more. Now, what I am going to talk to you about, I loved your story, and I think that's so real. And what I am going to talk to you about is from the doctor's perspective, and I think that's really important. And I'll tell you a little secret. Doctors, too, can be incontinent. Remember that. So remember that it's going to happen, or it may happen, not only to you, but it can happen to us. So by talking to us, you may actually make us voice out our problems more, and we can actually help each other. So remember that when you're talking to your doctor. Maybe your doctor is too shy to talk about his or her incontinent problems. All right? Now, I'm going to start off with a few stories. These are real stories in my clinic. Of course, the names are not real. So Linda actually came to see me. She belongs to another doctor. And I was wondering why she actually came to see me. But that was what she told me was because that doctor was a male and she didn't feel that that doctor would understand. But she came to see me, just said, I want a routine gynecological examination. So I did that. And after doing that, she actually asked me, do you think I look normal down there? Do you think that there's something different about me? And I thought that was such a leading question, because that question then actually opened up that whole bag of all her worries about the fact that she feels she does not have control. And she feels that maybe her uterus is falling down because she's not able to control her urine. She feels incomplete emptying of her feces. And that, of course, started that conversation about incontinence. Now, Mary, my 65-year-old lovely, lovely lady, I've known her for about 25 years or so. And she came to see me after a long time. The last time she saw me was before COVID. And she came to see me and she said, I've got rashes. And I said, okay, what's actually happening? She said, no, I think I'm allergic to some soap that I used. So I said, never mind, let me have a look at and see. Do you have any other problems? Do you feel dry down there? Are you having any other problems? Are you controlling your bladder? Are you feeling okay? And she said no to all my questions, because she said, I only have rashes. Then when I examined her, then I thought, I was getting a little bit suspicious, because there I saw she had a bit of a bladder prolapse, and I just felt that when I examined her, she was having a bit of a rectocele, and I was just wondering what was actually going on. But what the trigger was for me was when she took off her underwear and it actually smelt of urine. So then I thought, okay, I need to be very gentle with her, because she was not actually telling me what was actually going on. And then I asked her, what's happening? Are you going out of the house? Are you meeting your friends? Are the grandchildren coming along? And she said that she stopped going out and she was not picking up her grandchildren anymore, and she just felt she was more comfortable at home. And then when I dug deeper, and then I found that there were lots more other things that were going on, and that she was actually leaking a lot of urine, but she did not know how to bring that up with me, even though she has known me for the last 25 years, and she felt ashamed, and she felt that she was not a woman anymore. This is so typical, and so that's why I want you to think about the fact that if you do need to talk to your doctor about it, think about the fact that you might be actually doing your doctor a favor, that that doctor too needs to talk about his or her incontinence if they have it, because it is so common, and that's me in my clinic. Incontinence, you have more babies, unfortunately. It can bring about pelvic floor problems. If you're a little bit more bigger, if you have got chronic problems like asthma, you're coughing a lot, all that can actually lead to more pelvic floor problems, smoking, constipation. Remember that. It is so common that I see women with incontinence. I see about 1 to 2 women with incontinence every day in my clinic. And many a time, they don't say anything. And when I do ask them, I say, why didn't you tell me? Isn't that part and parcel of growing old? So these are real world conversations, and I'm not actually going to go into that whole bit, but I want to just say this one story of this woman who came to see me, and all she said was that she was just scratching down there, and she felt that she had worms, and she felt that she needed anti-worm medication. And when I said, I need to examine her, and she said, no, doctor, you're not going to examine me. And I said, I do need to, because I really need to see what's actually going on. So after a lot of pleading, she actually allowed me to see her, and she had a 3rd-degree uterovaginal prolapse, that she was also leaking feces. And I said, my dear, let me just help you through all this, and sent her to my gynaecologist, who then repaired her, and she's now very much better. So many of these might resonate with you or with some of your friends who actually need help. So I do hope that the take-home message here is that please talk to your doctor about it. There is nothing to be shameful about. Again, it can happen. It is just, I know we doctors are terrible. We just concentrate on certain things, and sometimes we are so busy. We understand that. Sometimes you feel that the doctor's younger, she wouldn't know what's going on. She wouldn't be able to empathize. The doctor is a male, what would they know? I'm having women's problems out here. But doctors do understand, and what our role is to educate our own healthcare professionals to make them more empathetic with all of you. So again, help us help you, which is really very, very important. Because you may think that we don't want to know, but we do want to know. So talk to your doctor. Sometimes you don't want to talk to the doctor, talk to the nurse, who will then take that message back to that doctor. Bring a friend who might ask the right questions. Bring a partner who might then talk to the doctor on your behalf. Or I get these kind of stories. Doctor, my friend has this problem. Good one, right? And when we have those ones, we already know who you're talking about. So you can always start off by saying, my friend has this problem. What should she do? And then we can actually go on and help you. So from the doctor's seat, what do? We actually, of course, ask you your history. We examine you. We may do some blood tests, because sometimes, when it comes to, we want to check out for infections, so we do that. We want to make sure that your diabetes is under control and whether you're having any infections, so that's very important. And even though you may be a bit reluctant for us to examine you, a pelvic floor examination is very important, because we want to then ascertain the degree of prolapse, if there is, and how we can go about helping you, because it does not mean surgery all the time. It might be just simple things, change lifestyle, treat your cough, treat the constipation, pelvic floor therapy, and even sometimes just to put a ring pessary or a medication to help control that incontinence, which actually would help tremendously. I see that sign, it's 1 minute, and from there, I want to tell you that, I want to end up by telling you that We are here for you. Please talk to us. Don't think that we would judge you negatively. All we want to hear is that you need help, and we would be there to help you, because you don't have to hold it in. Bladder issues are not your fault. It can happen to us. It can happen to you. Thank you very much.
Thank you, Dr. Premitha. I'd like to welcome Sharon. Sharon's a local Hobart resident, and she's here to talk to us about her stoma experience.
Hi everyone. My journey to incontinence started at the age of 40. I'm now 57, so it's been going a fair while. When I was diagnosed at 40, they tried a neurostimulator. I don't know if anybody knows what that is. Yeah. It goes wires into your back, and you have a remote control, and you can turn on your bowel and turn it off. Handy, but not. So when you go through like a shop where there's the alarms, it'd activate. Everybody would think I'm stealing something, and I'd go, I need to turn off my button, sorry. So that was a bit of a battle. Then that failed, so then we had to go colostomy. That was ×2, both failed. At this time I was working as a full-time carer in a nursing home, so I would bend over, try to shower somebody, away to go. Really embarrassing. Then I got sick again and ended up having an ileostomy. This one's permanent, no reverse, sewn up bottom. So when I pass wind, I don't know what's going to happen. I'll just get the noise in my bag, and it can be very embarrassing. You can be in a public place, in a bank. It happened to me recently, and it was my bag, and I'm just looking around as if to say, well, it wasn't me. So then I got a staph infection after hernia. So I'm cut from just under the breast right down. Now I've got heaps of other problems, but that's okay. Living with a stoma is a nightmare. Anybody who says that it's easy, it's not. When I go for a walk, I have to know where the toilets are, because you never know when it's going to go. I'm a full-time carer for my mum and dad, so showering mum, helping dad, it just all affects the stoma. Eating is a nightmare. Everything goes through me in a matter of 15 minutes. And with an ileostomy compared to a colostomy, ileostomy, I can't feel it filling up. So I'm always patting my tummy. Relationships, well, that's a nightmare. The only thing I could do relationship-wise, when he didn't understand, and not many people do know what a stoma is, that's my bag that I wear. It's self-opening, so I will empty that about 8 times a day. And getting your stock is a nightmare. But going back to this, because I just got sidetracked, I filled this cup, half of water, and put it on my partner's tummy, and I said, now carry that all day. See how it feels, because that's why I wear baggy shirts, because you never know when it's going to blow up or explode. So it's carrying this, a change of clothes, everything, every day. I hate it. I won't lie, I still hate it, and we're 6 years down the track. But non-reversible. I guess I'm here, and I'm not passed away, basically, because there was cancer cells, ulcerative colitis, which made them do the ileostomy. What else can I say? I've still got 3 minutes, whoops. Sorry.
Is it easy to get your equipment?
Absolutely not, no. You're allocated a certain amount of equipment, 30 bags a month. That's only just allowing you to change it twice. If you get a faulty one or it blows off, you need more, you can't get it. They say you've got your stock. Nightmare. So I've had to wear one for 2 days or something because I've run out, and then you get the infections.
Sharon, talk about the pain around the stoma.
Oh, Luckily, in 6 years, I've only had one infection. I was up camping up past Ooze, drove back to Ooze because I had shocking pain around the stoma. It was infected. Different changes of water will affect me. Food, nightmare. It's not pleasant. Everyone says, oh, well, you're lucky you're alive, but live with one. That's all I can say. It's really hard, really hard.
Yeah. Good.
That's it. I think that's all I can say.
I'm really proud of you.
Thank you.
Well done. I'll just add to Sharon's story, I'll just add something. When the adhesive is stuck to infected skin, there is no pain like it.
Oh, yeah.
So it's actually like a pussy sore that you are then sticking the bag to, and you have to keep that bag on for days while it is all pussy and sore underneath, and every movement, it's killer. So my sympathies. Sharon? Alan, please. It's my pleasure to welcome Alan. You might have seen him on the dance floor last night, surrounded by all the women. It was amazing. He was wonderful. Alan is a prostate cancer survivor, and he is a Bins for Blokes champion, and he's going to tell us a bit about his story.
Thank you. Aloha. Aloha. Mahalo. Okay, yes, dance floor. 50, 60 women with only a couple of males. How lucky can you be? Okay, so my story in 7 minutes. Let's find the right slide, make sure I'm talking about the right thing. So, robotic surgery, February 2011. February's a very busy month. Wife's birthday, St. Valentine's Day, and our wedding anniversary. And guess who lost their prostate mate in the middle of February? We did get to celebrate our wedding anniversary, and then it was all over Red Rover after that one. So it looked like Doctor Who, one of those machines, when I got rolled in, still half awake, and I went, oh my God, is this the machine sort of thing? And that's basically what it looks like. I will tell you that they're now developing them where it's only 1 or 2 arms maximum, which is quite fantastic. So, prior to this, I'd done what's called active surveillance. So I was diagnosed around 49.5 with prostate cancer, low grade, and back in 2000, they would just take it out. And I said, it's not coming out. I'm not losing my cherry again, thank you very much. So I did 10 years of what's called active surveillance, and then my yearly checkup, the cancer had come back, but actually it was actually aggressive. So I was between a rock and a hard place. So I bit the bullet and had robotic surgery. So that was an interesting little event. So I was wearing a catheter for about 8 days, strapped to my leg, had to change it each day, and after listening to these stories, I won't say any more about changing a bag. I mean, it was pretty easy compared to what you've just heard now, but it's all different. It's still incontinence. And men who get diagnosed with prostate cancer, don't know they've got a prostate and just don't even know where it is in the body, and then they've got to wear a catheter, and some of them still wake up the next morning going, what's this hanging out of my willy? I didn't get the memo about that one. Well, you did. You got told about it a week ago. But that's an interesting story in itself. So the interesting thing was, 10 days after the catheter came out, I didn't get the memo that I needed a pad, that I needed these pull-ups. And now I'm walking around like an 18-month-year-old again. I'm going a bit of memory back, flashbacks now. But luckily the urology nurse had them in the room. Losing the catheter was interesting. And then we pulled them up. Oh, it's so much better. So off we went for a coffee at our favourite coffee shop, sitting there drinking coffee, talking away. Went to stand up and I went, I've got a wet patch down here, compared to what you've heard, nothing. And I'm feeling real heavy in the crutch because this is full. I've got no sensation of leakage at all. That's gone for the moment. That did come back over a period of time. So from that day on, I do not wear light-coloured pants at all. That was a quick learning for me. So these were great in the beginning. Avalon Air Show, about 4 weeks after the surgery and walking around, I'm wearing a pair of these. I'm smelling the leather in the private aircraft. I went on a trade day so I don't have to mix with thousands of other people. Been able to walk into the aircraft, talk to the pilots. I'm ex-Air Force, so it was fantastic. And I was getting a bit heavy in the crutch again. Toilet trailers. I go in and I've got to get my jeans off, get my shoes off, pull this off. These toilets, you can't even swing a rat in them. They're that narrow. And I went, okay, I need to take this off, which I did in the cubicle. I walked out, went, what do I do with the pad? Luckily, there were big waste paper bins. But what if there hadn't been any? What do I do with that? So I did that 3 times in the day. Into the cubicle, take this off, walk out in the public arena of the trailer to drop it in the waste paper bin. Very interesting. Fast forward to Anzac Day, about 2 months later. Where is it on the slide? It's not on the slide, it's here. And I'm wearing a number 2. Let me just get that for you, because things are getting better. I'm wearing a number 2. So you know how the cricketers go out and they've got that little box they wear in their crutch, right? So I've got one of these going, oh, a bit of form here. No substance because I've lost length. Oh, sorry, length. Get a bit carried away there. Because when you lose your prostate, mate, you lose length and girth. So, and it's funny, men go, oh, was this long before the operation? Well, not really. The average is about 6.5, you know. It's a bit like catching the fish that got away sort of thing. No, it ain't like that. It never was that. I think you're living in a dream. So, Anzac Day, I'm finishing the march in Melbourne. I'm getting a little bit wet. I hope the hotel's got a bin. They did, but I still had to walk out and drop that in the bin. And I discovered very quickly my bloody didn't like too much alcohol, or coffee, or even cold weather. I'll give an example. Flew out here Thursday morning. I must have went about 5 times before I even left home. Got to the airport, another leak. Got here, another leak, and then nothing for 3 hours. The bladder just decided to quieten down. Maybe I was nervous, I don't know. But it turned cold that morning, and for me, and everyone's different, the bladder goes, uh-oh, I'm feeling a bit cold, let's get rid of this urine. It's a bit of a weird thing. So, how I got involved, I was invited to join the Consumer Advisory Committee, so they got the male voice. I'm the only rooster in the hen house, so to speak, at that time. I'm not complaining. It's important because incontinence for men is the first time I ever discussed this stuff. And when I've given presentations at men's sheds particularly, and I'm finished, blokes start to walk up and have a bit of a one-to-one. I say, how's the waterworks? They go, oh, look, I'm still leaking. I said, when was the operation? Oh, 18 months ago. I say, and you're wearing how many pads? You go back to your urologist. Something not right here. You need to get this sorted. You know, there's slings and artificial things or cuffs to put on. Men don't even realise that. Or I've stuck a couple of towels down the front of me and go, you can get pads for this. How can you have not been told about it? Because we don't talk about it. What? Can't be 1 minute. They don't get told where to go. The 1-800 number for Continence Health is important, 1-800-330-066, a bit like my tax file number, 327-788-0. Don't ask me why I remember that one. Bins relates to an important aspect. So if you mention this to women, and mostly women in here, they go, why haven't you got a bin in the toilet? Because blokes don't need them. They don't think we need them. So getting them into hotels, I don't even know if this hotel's got a bin. Maybe we all should go and check out the toilets if they've got a bin. But certainly we get in there. We've got them in at Swinburne University in Melbourne, which is fantastic. It's local RSL to put them in. The important thing is that even unisex toilets have bins, but we need a sticker. So it's no point putting this sticker on the inside of the door, unless you want me to go around opening every cubicle to find it. This tells blokes that they can go in, take their pad or their stoma and drop it in the continence bin, sanitary bin. That's the important thing, so they know they can access it. It's not on the outside of the thing. No sticker, no awareness. It's simple as that. And we need to all talk about advocating wherever you are to get toilets, particularly public places, Chadstone Shopping Centre, the shopping centre of the world, isn't it? I believe. You can get lost there. Go take a bus. Don't drive, just take a bus. They've got them in there, which is fantastic. So we get in there, Perth Airport, now we're working on a couple of other airports. So bins for blokes, the number, there's the website, fantastic, and have a read, print these out. Let's talk about it, because we don't talk about sex, when God don't even talk about incontinence or bladder and bowel. Too much information. We all do it, we're all human, so let's open up the conversation. Because once you do that, it normalises it and it gives the other person some permission to talk about it. As you've heard, they don't even want to raise it with the doctor. Go figure. So let's talk amongst ourselves. Thank you. Take the pad.
Well done, Alan. Thanks for that. Now it's my pleasure to welcome another local from Hobart. This is Emma. She's a pelvic floor physio.
Thanks, Leanne. It's wonderful to be here today. So my name's Emma and I work as a physiotherapist both at the Royal Hobart Hospital and at the Pelvic Studio, which is a private pelvic floor physio practice in Salamanca. And we're talking today about the power of pelvic health, and what we mean by that is bladder, bowel, sexual function. So we'll talk first about what is normal bladder function. A normal frequency or number of times that you go per day is considered 5 to 7. And 0 to 1 overnight, or 1 to 2 if you're over 65. A normal bladder capacity is 300 to 500 mils, so that's kind of 1 to 2 cups. And you should be able to feel the urge to go, but be able to override that if needed until you're at the appropriate place and the appropriate time. And of course, while leakage from the bladder is common, it's certainly not considered normal. There's two main types of bladder leakage when we think about incontinence. So there's urge urinary incontinence, where you get that really, really busting feeling and you're not going to make it to the toilet quite on time. There's common triggers for that. Sometimes people will be fine as they're driving home and they get home and they stick the key in the door and all of a sudden they've got to go as soon as they stick the key in the door. Or you might be fine, you're doing the washing up, you hear the sound of running water and all of a sudden you've got to go. Then the other kind of incontinence is what we call stress incontinence, which is when there's extra pressure down onto the bladder, so activities like coughing, sneezing, laughing or lifting, and you get leakage with those activities. There are other bladder symptoms that are considered not normal that are not exactly incontinence, so we'll talk quickly about them. So there's urgency, which is when you're getting that real uncomfortable desire to go. Frequency, so if you're going more than about 7 times a day. Bladder pain, which can happen either while your bladder is filling up, while your bladder is emptying, or after you've emptied your bladder. Hesitancy with your bladder is where you feel like you need to go, but it's not coming out, or you feel like you've got to really strain to get your wee to come out. And then incomplete bladder emptying. So you do your wee, you don't quite feel satisfied, or maybe you go away from the toilet and then 5 minutes come back and you've got to do a bit more wee. So all those things are considered abnormal. So how can a physio help with our bladder problems? Well, we know that pelvic floor muscle training is considered our first line conservative management for incontinence. But having an individualised and specific pelvic floor muscle training program is important. So there are lots of resources out there, and Continence Health Australia have some great resources on how to do your pelvic floor muscle exercises. But until you know what your pelvic floor muscle is doing, you don't know if you're actually doing those exercises correctly. We can also talk people through bladder training. So particularly if you've got that real frequent bladder habits, we can talk through timing your voids so that you're gradually stretching the interval between wees. And we can also look at your voiding technique. So that's how you're either standing at the toilet or sitting on the toilet to make sure that you're emptying your bladder completely and without straining. Let's talk about bowels now. So a normal bowel function is considered a soft and well-formed movement. So if we're looking at that Bristol stool chart, we're aiming for about a type 3 or 4. So it's like a sausage, but with cracks on the surface, or it's kind of smooth and soft. A normal bowel frequency is considered anywhere from 3 times a day to 3 times a week. So there is quite a range when it comes there. Similar to your bladder, you should be able to hold after you're first feeling the urge until you get to the appropriate place to empty your bowel. And then you should be able to pass out bowel motion easily without straining and without pain. And similar to our bladder as well, we should be able to completely empty the bowel. Other signs of bowel problems include bowel leakage, so that can either happen on the way to the toilet where you're getting that urge but you're not quite getting there on time, or it can happen without you knowing. So maybe you go to the toilet to empty your bladder and you notice a smear of poo on your underwear. A sudden overwhelming urge can be a problem as well, and that more commonly happens when our poos are a bit on the runnier side. Poor control of wind, which is something Leanne's talked about. Hard infrequent poos or constipation is considered not normal. If you have pain with opening your bowels, either while the bowels are filling or while they're actually emptying, that feeling of incomplete emptying, like there's not that satisfied feeling after doing a bowel motion, can be a sign of a problem. Or if you need to use your fingers to help empty your bowel, and that's actually more common than you might think. So some people will either use their finger inside their vagina to help them empty their bowel, on their perineum, or inside the anus themselves to get the poo out. So many people don't know that a physio can help with bowel problems, and we look at it kind of from a holistic point of view. Firstly, we want to make sure that your stool consistency is in that kind of 3 to 4 range on the Bristol stool chart, so that you're not getting constipated but it's not so loose that it's hard to control. We look at your defecation technique as well. Does anyone use a squatty potty or a footstool at the toilet? Good to see a few hands up there. So that can help us empty our bowel well. And then, of course, looking at our pelvic floor muscles and the muscles around the anal sphincter to maintain good control. Another condition that we commonly see is called pelvic organ prolapse, which we've heard a little bit about. So this occurs when the pelvic organs, and by that I mean the bladder, uterus and bowel, descend into the vagina because they've lost some of their support. And we commonly hear symptoms like heaviness or dragging, or I feel like there's a lump or there's something coming down into my vagina. Or sometimes people might feel that they can't fully empty their bladder or bowel, and that can be a sign of prolapse. And of course, physiotherapy is considered conservative management first line for prolapse. Pelvic floor muscle exercises are a big part of that to give us support from below. We can look at optimising your bladder and bowel emptying techniques so you're not putting too much pressure through the pelvis. We can look at lifestyle advice, so that might be managing your smoking or making sure you're doing the right kind of exercise so that you're staying healthy but not worsening your prolapse. And we can look at using a pessary, which is a device that we can fit inside the vagina to offer some support. There are a few other reasons that are not specifically continence related that you might consider seeing a pelvic health physio. So we'll run through those briefly. Pain with sex is one of those things. Pelvic pain, so that might be around the front or the back. If you've got coccyx pain or around your tailbone. If you've had a low back or hip pain that you've been seeing a physio for, doing exercises, it's not getting better, that's another thing. We consider pelvic floor physio part of standard care during pregnancy and after baby, and also before and after treatment for prostate cancer, whether that's surgery, radiation or hormonal treatment. A quick note about accessing pelvic health physios in Australia, or in Tasmania specifically. So you can go publicly and you can ask your GP or your specialist for a referral. And in southern Tasmania, physios are available at the Royal Hobart Hospital. I work up at Glenorchy Health Centre one day a week as well, and the community Continence service have physios. Of course, there is a waiting time for those services, and you can get in a bit quicker if you see privately, and there's a growing number of private pelvic health physios in Hobart, which is great. And you sometimes can get subsidies for seeing physios through a Medicare rebate if your GP refers you, or through a private health insurance rebate as well. And I'll be hanging around afterwards, so if anyone has questions, come see me. Thank you.